Lymphoma is cancer of the lymph nodes. Lymphoma. What you're going to have to know how to do is know what to do with a cancerous lymph node, and then a little bit about Hodgkin's versus non-Hodgkin's lymphoma. What you do not have to do is memorize all the details of all the subtypes of the different types of lymphoma. You do not have to memorize all the drug names for the drug chemotherapy regimens. Let's start off by talking about how you handle a non-tender lymph node and then work our way into the actual management of the lymphomas. If you see a non-tender lymphadenopathy, that is probably going to be cancer. Reactive lymph nodes, those that are not cancer, generally from infectious causes, are going to hurt. You poke them and they're tender. And those lymph nodes are reactive and there's not a cancer growing out of them into the surrounding tissue, so those lymph nodes are freely mobile. Freely mobile, tender, reactive lymph node, probably infection, whereas a non-tender and fixed, firm lymph node is probably cancer. Lymphoma, you probably remember, can present with B symptoms. You do not have to have B symptoms in order to have lymphoma. In fact, B symptoms are called B symptoms because it upstages the tumor from A to B. So B symptoms are part of the staging criteria, not the diagnostic. Your vignette might have B symptoms. But if you get a question about a non-tender lymphadenopathy, there is one answer. Excisional biopsy. And this is a board favorite. Going from I found a lymph node to cut the whole thing out is a big leap as you begin to study. What the instinct is to do a fine needle aspiration, put a needle in it and draw a sample. That's not good enough. When you cut out the lymph node and flay it open, you do immunohistochemistry stains, you see the cytoarchitecture of the lymph node, and you're allowed to do stains. So you need to cut it out to tell what cancer it is and to make the diagnosis of cancer, because the fine needle aspiration generally doesn't cut it. So if you see non-tender lymphadenopathy, cut it out. What you're going to see is either another cancer, in which case that lymph node is a metastasis or a highly staged tumor, and what you want to do is find the primary. And because you have the diagnosis, you know where to look. If you find nothing, go apologize to the patient for cutting out their lymph node. But before you do that, make sure it's not a reactive one. So you're going to do things like gram stain and culture, AFB smear, fungal. Because not all non-tender lymphadenopathy is malignancy. It can be a reactive lymph node, it's just that it's supposed to be tender. So before you throw it away, make sure it's not infectious. And then you can even go looking for connective tissue disorders, but I don't want you to go there. Excisional biopsy is going to show you lymphoma. And there's going to be two types of lymphoma, Hodgkin's and not Hodgkin's, called non-Hodgkin's. The difference is in that biopsy. If you see Reed-Sternberg cells, it is Hodgkin's. If you don't, it's non-Hodgkin's. So if you see on your vignette a picture of a stain, microscopic slide, showing you weird cells, it's probably going to be the Reed-Sternberg cells. That picture is telling you, hey, you made the diagnosis of lymphoma, those are Reed-Sternberg cells. That's Hodgkin's. If they're not there, non-Hodgkin's. But regardless of which cancer it is, the next step is the same, and that is to stage. I'm going to show you the traditional model and then talk about it. The first step of staging was a chest x-ray. And if that was negative, you did a CT scan of the chest, abdomen, pelvis. If that was negative, you need to rule out extensive disease by doing a unilateral bone marrow biopsy. The idea was, if you didn't have a complete stage on the chest x-ray, step up to the CT. If you didn't have a complete staging, step up to bone marrow biopsy. And you always had to do the bone marrow biopsy to rule out extensive disease. The new way of thinking, and this is not going to be on your test, but the new way of thinking is just do a PET scan. It turns out that chest x-ray is not sensitive enough and should just go to the PET CT anyway. And bone marrow biopsy, being positive or negative, generally does not change the management as we've shifted into giving systemic chemotherapy for all stages of lymphoma. Because the treatment's not going to change, there's very little need to put in a bone marrow biopsy. But if you look at other review sources, including internal medicine boards, they still say start with a chest x-ray and make sure you do a bone marrow biopsy. So this is on its way, and you can use it in discussion on rounds. But for your test, still choose chest x-ray, then the CT of the chest, abdomen, pelvis, or a PET CT, and do a bone marrow biopsy if these are negative to rule out extensive disease. So why the chest x-ray business? Well, the staging of lymphoma is based on the Ann Arbor system. And the stage is dependent on the number of lymph nodes and where in relation to the diaphragm they are. You can have 4 stages of disease. Stage 1 is going to be 1 lymph node, and because there's only one, it's on the same side of the diaphragm. If you have stage 2 disease, you will have more than 1 lymph node on the same side of the diaphragm. Stage 3 disease, more than 1 lymph node on opposite sides of the diaphragm, and stage 4 disease is metastatic. The idea being, if you got a chest x-ray and you saw 2 lymph nodes on the opposite side, you have pretty much the stage at a very high stage with a poor prognosis. Whereas if it was all negative, but the bone marrow biopsy came back positive, you'd have stage 4 disease, which is a poor prognosis. So the idea is that once you get to a high stage marked in red, you may not need to do any more work. But for your test, chest x-ray, if negative, CT scan, if negative, bone marrow biopsy. And notice we didn't separate out yet Hodgkin's versus non-Hodgkin's. Staging is the same for lymphoma. So let's talk a little bit about Hodgkin's versus non. If you have to have one of them, you want Hodgkin's. Non-Hodgkin's has a much worse prognosis. Hodgkin's results in remission or cure in most cases. Over 80% will have cure. The problem is that you get chemotherapy and radiation, so you end up with complications of the therapy that kill you later. So you don't want lymphoma, but Hodgkin's is better because you get cured. Non-Hodgkin's lymphoma, you can put them into remission, but generally 7 to 10 years later it comes back. And most patients with non-Hodgkin's lymphoma will die from a lymphoma-related illness. Hodgkin's lymphoma generally does present with B symptoms, night sweats, fevers, and weight loss. But despite that, Hodgkin's generally presents at 2A or better. Non-Hodgkin's generally does not have B symptoms and presents at 2B or worse. Hodgkin's is going to spread contiguously. That is, most of the tumor burden is going to be right in the area that the tumor originated in. Again, owing to its better prognosis because you're able to target the area that it actually is infected. And it doesn't get very far until it's quite advanced. Non-Hodgkin's spreads hematogenously. So it can be anywhere, and it's much harder to target your chemotherapy and radiation. So there's some unique things about each one that sometimes come up. Hodgkin's has the Pell-Epstein fevers and the alcohol lymph nodes. When patients with Hodgkin's consume alcohol, that non-tender lymphadenopathy becomes painful. Just know about it. And while patients may have B symptoms, those recurrent fevers, the Pell-Epstein fevers are cyclical fevers. The things that non-Hodgkin's generally gets tested on is the Burkitt's lymphoma, the starry sky pattern, be able to diagnose it on histology, and it has extranodal disease. There is a shift to treat everybody with radiation and chemotherapy. And so for Hodgkin's, the chemotherapeutic regimen is going to depend on how bad it is. You do not have to know the names of the drugs in the regimen. That is, do not memorize the regimens, because the regimens are often named based on a combination of trade and generic, which makes it unfair for you to memorize. But you do want to be able to recognize them and know their side effect profiles. Hodgkin's is treated with ABVD. Almost every form of Hodgkin's is going to get ABVD, but if you have really bad disease, you get treated with Bayakop. Bayakop is a worse regimen. It has lots of toxicities, and you only use it when there is really bad lymphoma. Really bad lymphoma usually means really bulky disease. You will not have to assess prognosis, which one is bad, which one is good. ABVD for not that bad Hodgkin's, Bayakop for really bad Hodgkin's. Non-Hodgkin's is treated with either rituximab alone, R, or a combination chemotherapy, R-CHOP. ABVD, Bayakop, Hodgkin's, R-CHOP, non-Hodgkin's, rituximab based. We're going to close with an advanced organizer that will help you remember those side effects that you need to know. And that is Chemoman. Chemoman is a nice rotund gentleman. He needs to be rotund for the last complication, as we'll get to. His arms and legs are in the shape of a V. To remind you, arms and legs, peripheral neuropathy. They're in the shape of a V because vincristine and vinblastine cause peripheral neuropathy. Now, most patients who are alive have a heart. And in the heart is an atrium. A for adriamycin. Adriamycin is the trade name for doxorubicin and daunorubicin. Doxorubicin, daunorubicin, cardiac toxicity, specifically dose-dependent and irreversible cardiomyopathy, heart failure. Patients have lungs, and the lungs are in the shape of a B. B for bleomycin. Bleomycin causes pulmonary fibrosis. He needs ears and kidneys in the shape of a C. C for cisplatin. Cisplatin causes ototoxicity and nephrotoxicity. And lastly, we have this rotund gentleman. So we have down here a half pipe. And in a half pipe, you might do some extreme sports like BMX. And for BMX, you need a bicycle. Bicycle for bicyclophosphamide. Cyclophosphamide causes hemorrhagic cystitis because down here between the legs is the bladder. In general, getting chemo and radiation predisposes you to other malignancies, especially Hodgkin's lymphoma. You treat it for it, you end up with non-Hodgkin's because of the chemo and radiation, or thyroid cancer. From the actual drugs themselves, cisplatin causes ototoxicity and nephrotoxicity. Vincristine and vinblastine, peripheral neuropathy. Cyclophosphamide, hemorrhagic cystitis. Doxorubicin, daunorubicin, cardiac toxicity, dose-dependent irreversible heart failure, and bleomycin causes pulmonary fibrosis. Lots to memorize there, but also recognize that it's going to be really easy when you identify the non-tender lymphadenopathy, you cut it out, and then you stage. That's lymphoma.